Don't worry, you have not taken the wrong channel. This is GH Today and this still is Health Check. My name is Nanama Anna Bempong and today we are going to be speaking with Dr. Paul Enin at the Airport Women's Hospital. And today we're going to be speaking about artificial reproductive technologies. Dr. Enin, thank you so much for joining us on Health Check today.
Thank you.
As we said, we are talking about artificial reproductive procedures. Sounds like a mouthful. What exactly does that mean?
Well, artificial reproductive technology means new systems that are in place to assist in reproduction.
Okay.
And essentially, under those tests, we're talking about artificial insemination,
Okay.
and in vitro fertilization,
Okay.
and other ancillary procedures that support the IVF platform.
What are the reasons that people would need to use an artificial reproductive technology?
It's commonly done for male subfertility, commonly done also for women with ovarian dysfunction, also done for women with uterine problems, and commonly done for a couple who have tried other means and have failed, and therefore want to use more sophisticated systems to achieve pregnancy.
But, you know, in this here, our culture, especially, I think, if I'm not wrong to say, a lot of men kind of push the issue onto women. You know, it can never be me, it can never be me. So a lot of women are checking themselves out and things are okay, but they're still not getting pregnant. What would you say to those types of couples to make people know that it's more of a two-sided thing?
Well, as you said, it's a two-sided thing. You got married to a woman, and therefore, and you want to have children, and it's an issue for the couple. And when we start investigating or start assisting, we are trying at every stage. So both people are involved. So if we are even if we are stimulating the woman only, the man must understand what is going on so that he can know when to mate with a woman. It's not that you prepare the woman and then the day that the woman is ovulating, the man is out with his friends drinking.
Okay.
You know, so it's an issue involving both people. And when we come to statistics, when things are going wrong, we find abnormalities in about 40 to 50% of women, and we find abnormalities in about 40% of men.
Okay.
So the issue of infertility or subfertility in men and women are almost balanced, and that they should approach it as a couple. There are issues involving both sides.
Okay. So, somebody comes to you, things are not going the way that they had intended or that they wanted. What would be the next step?
Well, the next step, commonly, I'm sure a lot of people have exhausted their issues with women. That's why you skewed some of these discussions towards men, because men have been ignored in terms of don't even know that they have issues. And but certainly for in vitro fertilization, I've mentioned the ovulatory factors with a woman. We've mentioned age in women is an issue, and the fallopian tubes through which the egg has to be picked and meet the sperm halfway. Could also be blocked.
Okay.
And in the past, when tubes have been blocked, doctors have done all kinds of things, including hearing that, women say, we're going to wash our tubes, something that doesn't exist. And I hope that those who are doing it would desist from it.
Okay.
Because there's nothing like washing the tubes.
Okay.
We do blow some air or some solutions into the tubes, but it's all been found to be, a lot of it is ineffective. And
Okay.
since there are better means of doing it, but it's expensive, we need to explain it to the women that there are better options and we shouldn't be wasting our time on procedures that don't yield results as much as going for the more sophisticated procedures like IVF. So if we move to the IVF as the treatment, then a couple who may have nothing even abnormal. You've tested the man, done his sperm count, you've tested the woman, checked eggs, everything is fine, but yet they still cannot get pregnant. We give them IVF or even intrauterine insemination, IUI, as part of the solution. And we tend to do the IUI first because it's cheaper.
Okay.
Then if it doesn't work, then we go to IVF.
So sorry, go on.
But certainly when somebody has a blocked tubes, if you did IUI, means that the egg, intrauterine insemination means that the egg will pass through the tubes and the sperm would meet it from the vagina or from the uterus. So the tube is blocked, you can't do artificial insemination. You would have to do in vitro fertilization, IVF. And what is IVF? IVF means creating fertilization outside the womb.
Okay.
And to that end, we again want to stimulate a woman to produce more eggs, to produce quality eggs.
Okay.
And if after she's produced the eggs, we just give her some sedation so that she doesn't feel the process, but we put a needle into the abdomen and take the eggs out.
Like how big are they?
The eggs, they can be sometimes as big as a grape.
A grape, wow, okay.
Yes. So if you can imagine a grape with a seed in it, then the egg that we're talking about will be the seed.
Okay.
But then it comes
packaged
like an egg. The yolk is the thing, and then there's a fluid around it, in which, so we put a thing and suck the fluid out of each follicle, and the embryologist then separates the actual egg that we're going to use from it under the microscope. Okay. So that is how that is done. Now, after you've gotten the egg, then we take the man, again also take the sperm or the semen by masturbation, and then we process the semen also separately. After we've gotten the semen and concentrated it, we then take it to the embryologist, who will then join the two at some stage. Joining the two also involves either you put the sperms on the egg, or we actually, if we don't have enough or the quality is not good enough, then we may select certain specific sperm that we think is good and inject it directly into the egg. So if you want to look at what we call intracytoplasmic sperm injection, ICSI, It's like taking the yolk of an egg and injecting a sperm into it. Okay. Basically, that's what it is.
Okay.
And the egg and things that we talk about is no different from the egg that we eat.
Okay.
The whitish fluid around the egg, or the clear fluid, is also seen in the, and then the yolk is the real thing that we're looking for in terms of fertilization. Mm-hmm. So if you can imagine that, then that's what is happening.
Okay.
When the tube is blocked, then you come to the problem with the quality of the eggs. All the other procedures that come after also depends on the quality of the gametes, as the egg or the sperm. Okay. If the egg we think is no good, and women over 40 have to also be addressed. But because of age, you may not produce, you may have eggs, but they may not be quality eggs. Okay. Hence, you may get pregnant with them and then have a miscarriage. And we have statistics to back us up that if you're going to spend money to try to get pregnant for somebody who doesn't have you don't have a child, then we encourage you to understand that if you use your own eggs, the quality may be poor, and therefore there's a risk of a miscarriage, even after you fertilized. Hence, we get into the area where we call donor gametes, where somebody donates an egg for you. Okay. Or you buy, we don't want to use buying sound. So somebody donates an egg, or somebody donates a sperm. Okay. Because if some men don't produce sperms at all, or we've used the sperms and we find that every time we're not getting good results, after fertilization, we can only observe for about 5 days, beyond which we have to put it inside the woman. Okay. And when we've observed some beyond 5 days, we find out that the union of fertilization, the development of the embryo was no good, because the quality of the sperm or the quality of the egg was not good to begin with. And we have certain things that tell us which eggs are not going to be good. And for women, age is the number one factor. Women over 40 or around 40, but that is not to say that we cannot have women. In this day and age, when you're using donor egg, you can create a situation where even somebody who is in menopause can be impregnated or can have a baby. Again, I can say that, whilst I'm here, I can say that, thanks God, we have been able to have a woman 54 and 55-year-old pregnant in our institution. Great. And many more, when 45, 50, thereabouts are all coming in. And IVF has opened a way for older women. And because women's careers have gone older, older women are now trying to get pregnant. And therefore they may start at 35, before long they are in 45. And all these other procedures now come in to assist them. Okay. The age factor can be circumvented with the donor schemes. But not only that, I'm sure you've heard about surrogate motherhood. That's somebody whose uterus may be diseased, cannot carry pregnancy because of that the husband is okay or she herself is okay. So we can again create embryos from their egg and sperm, but they cannot carry the embryos. So we have to have somebody carry for them. If we have somebody whose system has been tested, somebody who has her own children, doesn't need any child, but decides that she'll carry, for them, that's what surrogacy is all about. Yeah. So you can have a family member carry it, or request somebody to do so for you, sometimes at a cost, but it all can be done.
My friend did that for her sister, and I was happy for her because she herself had 2 children, and then she did that for her sister who couldn't have. So I mean, if you can help someone out, why not?
Why not?
Yeah.
Definitely.
What are the statistics regarding artificial technologies for reproduction? Because obviously, like you were mentioning, it's quite expensive. But I believe that now, as it's becoming more common and people are getting to know more about it, the price, I believe, may reduce or something like that. But I mean, what are the percentages or the statistics for that?
That's a good question, and a very controversial one in this area of discussion. There is getting pregnant, and there is having a live birth. So as I said, you can have a pregnancy. So some people can say, okay, we have 50% pregnancy rate. But then what is your take-home rate? Carrying a baby home. So you can have women come in, you do the IVF. But I would say in general, it is safe to say about 30%. Some people even argue that it might even be lower. But no, the techniques have improved. So a take-home rate of about 30% is, but in terms of fertilization, some good centers are getting about 70% fertilization. Then as you go along, some of the pregnancies will drop along the line, either because the womb itself, if you plant on the rocks, it will grow up to a certain point and then it can't grow again. So some of the pregnancies are going to fall on the wayside. So when we talk about rates, I mean, we all want to bump our rates up. So we tell you our pregnancy rates, but we won't tell you the miscarriage rates that come along. So we say, I mean, my first pregnancy, my first IVF I did, I was successful. Thank God. So at that point, my pregnancy rate was 100%. So it goes on and on and on. Sure. But the average, to be fair, is about 30%, between 30 to 50% range.
Okay.
Yeah.
All right. That has been Health Check today, and we've been talking to Dr. Paul Enin at the Airport Women's Hospital. We were speaking today about artificial reproductive technologies, and I hope that is giving you some kind of hope that even if you can't have children, you will be able to in the future with some assistance.